Pathophysiology of bronchitis, step-by-step detailed process. Bronchitis is the inflammation of the bronchial tubes, which are the airways that carry air to the lungs. It can be acute, short-term, usually due to infection, or chronic, long-term, mostly due to irritants like smoking. Primarily focused on the acute form, but also integrating chronic elements where relevant. Step-by-step pathophysiology of bronchitis. Exposure to irritants or infectious agents. Acute bronchitis, caused by viral 90% or sometimes bacterial infections, e.g. Mycoplasma pneumonia, Chlamydophila pneumonia. Chronic bronchitis, caused by long-term exposure to irritants like cigarette smoke, air pollution, or dust. 2. Entry into respiratory tract. Pathogens or irritants enter the upper respiratory tract and migrate to the bronchial epithelium lining of the bronchi. The mucociliary clearance system attempts to trap and remove the pathogen's particles. 3. Activation of the immune response. Inflammatory mediators such as interleukins, IL-1, IL-6, and tumor necrosis factor alpha, TNF-A, are released. Neutrophils, macrophages, and lymphocytes are recruited to the site. Vasodilation and increased capillary permeability occur, leading to redness and swelling of bronchial walls. 4. Inflammation and swelling of bronchial walls. The epithelium becomes edematous, swollen, due to fluid leakage from capillaries. Goblet cells and submucosal glands become hyperactive and produce excessive mucus. In chronic bronchitis, there is hypertrophy and hyperplasia of these mucus produced. 5. Mucus hypersecretion. Mucus becomes thicker and more viscous. It obstructs the airways and reduces airflow, especially during expiration. The ciliary function is impaired, leading to decreased clearance of mucus and pathogens. 6. Cough reflex activation. The accumulated mucus and irritation of bronchial walls stimulate the cough reflex. Coughing is an attempt to expel the mucus and clear the airway. 7. Bronchospasm. In some cases, in response to inflammation, the smooth muscles of the bronchi may constrict. This leads to bronchospasm, further narrowing the airway and causing wheezing and dyspnea, shortness of breath. 8. Impaired gas exchange. Due to airway obstruction and inflammation, ventilation is reduced. Mismatched ventilation perfusion, VQ mismatch, can occur. In chronic bronchitis, hypoxia, low oxygen, and hypercapnia, high CO2, may develop over time. 9. Chronic inflammation. In chronic bronchitis, prolonged exposure to irritants leads to chronic inflammation. This causes permanent changes in the airway, such as fibrosis, thickening of bronchial walls, airway remodeling, pulmonary hypertension due to vasoconstriction in response to hypoxia. Chronic bronchitis specific changes, defined clinically as productive cough lasting for at least 3 months in 2 consecutive years. Structural changes include squamous cell metaplasia of bronchial epithelium, increased Reed index ratio of gland thickness to bronchial wall thickness, airway narrowing, and obstruction. Conclusion. The pathophysiology of bronchitis is a dynamic interaction between inflammatory responses, mucus hypersecretion, and bronchial structural changes. In acute bronchitis, most changes are reversible once the infection clears. In contrast, chronic bronchitis leads to progressive and irreversible damage to the bronchial tree. Thank you. Have a nice day.